This content is AI generated for informational purposes only and should not be directly used for clinical decision-making.
Hello and welcome back to the Neurosurgery Hub podcast. I'm Dr. Aris, Senior Attending Neurosurgeon, and today we are tackling a document that I believe will be the cornerstone of our practice for the next several years.
And I'm Dr. Alara. Today we're looking at a fascinating new study from the European Stroke Organization, ESO, the European Association of Neurosurgical Societies, EANS, and the European Society for Minimally Invasive Neurological Therapy, ESMINT. This is the 2026 Joint Guideline on the Management of Aneurysmal Subarachnoid Hemorrhage, or aSAH.
It's a massive undertaking, Ilara. When you see three organizations like ESO, EANS, and ESMINT coming together, you know the goal is to break down the silos between neurology, open neurosurgery, and interventional neuroradiology. For our residents and fellows listening, this isn't just another paper. It's the new law of the land for aSAH in Europe, and likely much of the world.
Exactly. And what's interesting is the sheer breadth of the authorship. We see names like Mervyn Vergouwen, Anna Ramos-Pashin, and Nima Atmanen leading the charge. They've synthesized a huge amount of data to answer the most pressing questions we face from the moment a patient hits the ER.
Let's start at the beginning, diagnosis. The 2026 guideline is very clear on the diagnostic pathway. Ilara, what are they saying about that initial thunderclap headache?
The paper reinforces that non-contrast CT remains the first-line investigation, but it goes deeper into the timing. If the CT is performed within 6 hours of headache onset and interpreted by a neuroradiologist, its sensitivity is nearly 100%. The big talking point in the 2026 update, however, is the role of the lumbar puncture.
Right, the CT-negative LP mandatory rule. Does the guideline offer any flexibility there?
It emphasizes that if the CT is high quality and performed early, the added value of an LP is decreasing, but it remains the gold standard for those presenting later, specifically after the 6-hour mark, where CT sensitivity starts to drop. They really want us to focus on spectrophotometry for xanthochromia, rather than just a visual inspection of the CSF.
Which is a vital point for the residents. You can't just hold the tube up to the light and say it looks clear. Now, once we've confirmed the subarachnoid blood, the next step is finding the source.
This is where the ESMINT and EANS collaboration really shines. The guideline suggests CTA as the initial vascular screening tool because of its speed and availability. However, digital subtraction angiography, DSA, remains the reference standard, especially when the CTA is negative or when we're planning complex interventions.
Let's get to the meat of the matter, aneurysmal treatment. This has historically been a point of contention between the clippers and the coilers. How does the 2026 guideline bridge that gap?
It's very diplomatic but data-driven. The paper states that for aneurysms where both endovascular coiling and neurosurgical clipping are technically feasible, the decision should be made by a multidisciplinary team. They highlight that coiling is often associated with better short-term functional outcomes, as we saw in the original aSAH data, but clipping offers higher rates of complete occlusion and better long-term durability.
I noticed the guideline mentions specific anatomical considerations, for example, middle cerebral artery, MCA aneurysms.
Yes, they specifically point out that MCA aneurysms often favor clipping due to their frequent association with large intraparenchymal hematomas and their complex bifurcation anatomy, which can make coiling difficult without stenting. On the flip side, for elderly patients or those with a poor World Federation of Neurosurgical Societies, WFNS, grade, endovascular treatment is generally preferred to minimize the surgical second hit.
And what about timing? We used to talk about early versus delayed surgery. What's the 2026 stance?
The consensus is earlier is better. The guideline recommends securing the aneurysm as soon as possible, ideally within 24 hours of symptom onset. This is primarily to prevent the catastrophic risk of rebleeding, which they note is highest in those first few hours.
I'm glad they emphasize that. I tell my residents all the time, a secured aneurysm is a patient you can safely manage in the ICU. An unsecured aneurysm is a ticking time bomb. Speaking of the ICU, the guideline spends a lot of time on delayed cerebral ischemia, or DCI.
DCI is really the black box of aSAH management. The paper makes a clear distinction between vasospasm, which is a radiological narrowing of the vessels, and DCI, which is the actual clinical deterioration or infarction.
And in terms of prevention?
Nimodipine is still the king. The 2026 guidelines give a strong recommendation for oral nimodipine for all patients for 21 days. Interestingly, they looked at the data for extended release formulations and intra-arterial delivery, but for standard prevention, 60 milligrams every 4 hours remains the benchmark.
What about the old triple H therapy? Hypervolemia, hemodilution, and hypertension. I still see some older attendings pushing fluids until the patient is in pulmonary edema.
The 2026 guideline is quite firm on this. Hypervolemia and hemodilution are out. They recommend euvolemia. The only H that stays is hypertension. They suggest induced hypertension only when DCI is suspected or confirmed, not as a prophylactic measure. They want us to target a mean arterial pressure or a systolic blood pressure high enough to reverse the neurological deficit.
That's a crucial distinction. We're treating the patient, not the angiogram. Now, let's talk about a complication we see every day, hydrocephalus.
Right. The paper notes that about 20 to 30% of these patients will need an external ventricular drain, EVD. For those with chronic hydrocephalus, the recommendation for a ventricular peritoneal shunt is clear, but they also discuss the use of lumbar drains as an alternative or adjunct, particularly to help clear the subarachnoid blood and potentially reduce the incidence of DCI.
I was interested to see their take on antithrombotic therapy. Many of our patients are on aspirin or clopidogrel when they bleed.
That was a complex section. The guideline suggests that if a patient was on antiplatelets prior to the bleed, they should generally be discontinued and reversed in the acute phase. However, for those undergoing endovascular treatment with stents or flow divisors, the need for dual antiplatelet therapy, DAPT, creates a delicate balance. The EANS ESMINT group recommends a tailored approach, often using shorter-acting agents if possible.
It's all about the balance of risk. Now, Ilara, as a research fellow, what did you think about their research priority section?
It was very insightful. They are calling for more robust trials on the ultra-early window, treatment within 6 to 12 hours. They also want more focus on neuroprotection. We've been successful at securing aneurysms and treating vasospasm, but we still struggle with the primary brain injury that happens the second the aneurysm ruptures.
Very true. The early brain injury phase is where we lose a lot of ground. I also appreciated the mention of seizure prophylaxis. It's been a debated topic for years.
Exactly. The 2026 guidelines suggest that routine long-term seizure prophylaxis isn't necessary. They recommend a short course, perhaps 3 to 7 days, in the immediate post-bleed period, particularly for patients with intraparenchymal blood or those who had a witnessed seizure at onset, but they discourage keeping patients on levetiracetam for months without cause.
Let's talk about the long term. aSAH isn't over when the patient leaves the ICU. What does the guideline say about follow-up?
They emphasize the hidden disabilities, anxiety, depression, and cognitive fatigue. The 2026 guidelines recommend standardized neuropsychological screening for all aSAH survivors. From a surgical perspective, they recommend follow-up imaging, usually MRA or CTA, at specific intervals to check for aneurysm recurrence or the development of de novo aneurysms.
It's a comprehensive roadmap. For the residents listening, if you're on call tonight and a Hunt and Hess Grade 3 comes in, your priorities according to these guidelines are 1. Confirm with CT/CTA, 2. Stabilize and manage blood pressure, 3. MDT discussion between neurosurgery and interventional for the best treatment modality, 4. Secure the aneurysm within 24 hours, 5. Start nimodipine and maintain euvolemia.
And don't forget the EVD if there's ventricular megaly on the scan. The guidelines also highlight the importance of high-volume centers. They state that patients with aSAH should be managed in centers that see at least 60 to 100 cases a year, as the outcomes are significantly better.
Which is a strong argument for the regionalization of neurovascular care.
Absolutely. Dr. Aris, what's your biggest takeaway from this 2026 update?
It's the shift towards precision and multidisciplinary collaboration. We're moving away from "this is how I've always done it" to a more nuanced, evidence-based approach that combines the best of all three specialties, ESO, EANS, and ESMINT. It's a great time to be in the field.
It really is. The full text of the European Stroke Organization, European Association of Neurosurgical Societies, and European Society for Minimally Invasive Neurological Therapy, Guideline on Aneurysmal Subarachnoid Hemorrhage, is available now. It's a must-read for anyone in our specialty.
Well said, Ilara. That's all the time we have for today. To our listeners, keep these guidelines in mind on your next call, and we'll see you next time on the Neurosurgery Hub podcast.
Thanks for listening.